Welcome to today's talk on preparing for parenthood. We thank you all for joining us for this year's Baby and Family Fair. We're so excited to be back in person, thankfully, and look forward to talking with you all about all things pregnancy and parenting today. So I'm Gail Simpson, and I'll be your moderator. I'm a registered nurse on the family care unit there at TMH. So I'm joined by Dr. William Doback. He's a maternal fetal medicine physician at TMH, as well as Dr. Kelly Verstoffel. She's an OBGYN with Gynecology and Obstetrics Associates at TMH. Becky Stewart, there in the middle. She's a neonatal intensive care nurse, also there at TMH in the NICU. And then there's Miriam Gurniak, near the end there, a certified nurse midwife at TMH. And then on the very end, Deborah Connors. She's a licensed mental health counselor at TMH's Behavioral Health Center. So I'd love for everyone to briefly share a little bit about what they do. And we're gonna start with Deborah there. Why don't you go first?
Hi, I'm Deborah Connors. I'm a licensed mental health counselor and I work at TMH's outpatient program. I am the adult therapist there. We only have 2 therapists. And so I see anybody 18 and older mostly, including moms who've just had kids. So.
I'm Miriam Gurniak. I have only ever worked in North Florida since 1996. I am a midwife currently with the Family Practice Residency Program. I have labor and delivery shifts at TMH where I deliver babies. I have triage shifts at TMH where I assess whether or not it's time to come in or it's okay to go home. And I also do prenatal care in Madison, Jefferson, and Taylor counties as part of the Family Practice Residency Program, and take the residents with me to help them learn about rural health care and rural maternity care.
Okay, Becky.
My name is Becky Stewart, and I am a registered nurse. I have been at TMH my whole career in the neonatal intensive care unit. I've just hit 20 years. I'm also a certified neonatal intensive care nurse with a bachelor's in nursing.
Okay, Dr. Verstoffel.
I'm Kelly Forstoffel. I work at Gynecology and Obstetrics Associates of Tallahassee. I'm one of the OBGYNs there. I trained up in New York and came here a couple years ago where my mother works, so I joined her in her practice, and I see obstetric patients, gynecological patients, all of the above. So happy to be here.
And Dr. Doback.
Good morning, Bill Doback, maternal fetal medicine here at TMH. We work with the great providers here in town, kind of helping with any pregnancies. If there are any maternal complications or any sort of fetal issues, we kind of help coordinate care and help make plans to get the best outcomes possible.
Okay, well, thank you all. Before we get started, though, if anyone has any questions throughout the discussion, we will take them at the very end, okay? So you can just make your little notes, and then we'll talk about them at the end. So, Dr. Verstoffel, let's start with some basics. What happens for women's bodies during pregnancy and after giving birth, whether it's cesarean or vaginally? What can moms expect?
So nothing about this is basic. So I will say that it's pretty interesting. Every part of your body changes in pregnancy, from your head to your toes. You know, you get this brain fog in your head, you get smelly feet in your toes. You know, it's all different. But there's different ways you can kind of think about it. You can think about it systematically, where every part of your body, every system of your body changes. You could do it by trimester. So we'll kind of go through both of them. Systematically, a big one is skin changes. So when you're pregnant, you might get darkening of your skin. You might get those spots like melasma. You could get that linea nigra, which is that line that goes up and down on your belly. You may get things like stretch marks or spider veins. That's pretty common. It doesn't all have to be bad, though. You can get things like great hair growth. You got like the fullest hair of your life when you're pregnant. You have the strongest nails ever. So it's really great. You might have acne in the beginning especially, but maybe you're really lucky and you get that nice pregnancy glow, which is like that flush in your face. So it's really nice. So not all of it's horrible. Brain changes, like I said, that brain fog and feeling like you're drained all the time, especially in the first trimester, maybe a little bit of insomnia first and last trimester. That's pretty common. Definitely some breast changes. So one of the first signs of pregnancy might be some breast tenderness or engorgement, might be to cue you into that you might be pregnant. Some darkening of the nipples, that's very physiologic, right? Baby's gonna be looking for your breasts, and so it's a way for them to kind of cue into where they need to go. Maybe in the last trimester, you could even leak some colostrum, making that early breast milk that's really, really nutritious for the baby. Even things like your heart changes in pregnancy, so you might have a higher heart rate than you normally do. You might feel like episodes of your fast heart beating. Definitely some lower blood pressure than you are normally used to. So when you go to your prenatal visits, it might be much lower than what you usually see. Lungs-wise, you absolutely get short of breath much easier. That baby, as baby grows, kind of pushes up against the diaphragm a little bit, so it might be harder to take that big, deep breath, or when you lay really flat, baby kind of rolls up into the lungs, and it kind of becomes a little uncomfortable. GI is a big one. I think most people come into their visits and complain about GI issues. You have a lot of hormones in your body, and the point of those hormones are to relax, especially your abdominal wall, as you stretch. It's a very normal part of pregnancy. But in response to that, other things in your body relax. So things like your esophagus, right? That would give you a lot of heartburn in pregnancy, maybe your bowels or your gut, right? And that gives you a lot of bloating or constipation. So I think half the battle of pregnancy is dealing with your constipation. Definitely a lot more urine that you're making. You're gonna be peeing all the time, especially first trimester and last trimester. A lot of times people get cued into their being pregnant with peeing all the time. And then a big one too is your musculoskeletal system, right? So your muscles, your bones, things are a lot different. So you might have a little more back pain. You're not used to carrying a big watermelon in front of you, so it's a lot of strain on your back. And you kind of like arch your back to accommodate baby a little bit. So you're walking around like with the pregnancy walk. You have a lot more hip laxity in pregnancy, so you might feel like that when you're walking around. It makes sleeping different, it makes walking different, it makes sitting different. So a lot of different changes of every part of your body. Trimester-wise, I mean, because these things, some people have all of these, some people have none of them, some more than others. Majority of them do resolve postpartum by about 6 weeks, but sometimes could take a little longer, and some things you might have the rest of your life. But trimester-wise, like I said, cueing into being pregnant first is kind of comes a little bit of breast tenderness, maybe a little nausea, vomiting, definitely exhaustion. You feel like you want to take a lot of naps multiple times a day in the middle of the day, maybe increased peeing throughout the day. Second trimester, you're start getting a little more weight gain, maybe a little bit of round ligament pain. So that's going to be pain kind of in that lower pelvic area as your uterus is stretching and kind of growing very quickly. Heartburn, constipation, those kind of things. And then third trimester, a lot of that stuff kind of resolves, but you'll get more of your GI issues, maybe increased discharge, maybe some of that breast milk that I was talking about earlier, swelling in the legs, leg cramping, those kind of things. So all of it, your whole body changes. It's actually quite fascinating how our bodies are able to do this, and every part of it has a reason. And again, you might have some, you might have others, you may have none of them, that would be nice, but all of it's pretty normal. And then, like, you know, what can you expect? All of the above, all of the above.
Well, thank you. So all of that sounds pretty familiar to me. What are some of the physical changes or symptoms that surprises moms after birth?
I think that some of the biggest ones that people after they deliver seem to bring up a lot that they didn't realize were shaking is a big one. So right after you deliver the baby, you seem to be, it seems like shivering, but you're not really cold. And that's very normal. You have a lot of hormonal shifts, a lot of fluid shifts. You just went through this whole adrenaline thing where you delivered a baby, and that's a lot for your body. And so you'll be unable to kind of control this little shake that you have. And it doesn't last very long, usually 30 minutes, an hour at most, but it is pretty common. Most people have that. Things in the postpartum periods, you will bleed. And that tends to get better and better as you get closer and closer to that 6-week period, and usually resolves by 6 weeks. In the beginning, it's kind of this trickle of bright red, goes to dark red, they may be brown, and then sometimes even turns white in the end, which is a little strange, but it's pretty normal. And then by 6 weeks, it's usually back to normal. You swell a lot postpartum, so a lot of people are pretty surprised that when they're on the postpartum floor, their legs are actually bigger than what they were in the third trimester. And so your body has to like change this whole fluid shift that it did. So usually a few days after, you will pee like a waterfall. and it all goes away. And if it doesn't, that's when you call us and let us know what's going on. Afterbirth pains, so especially for breastfeeding mothers, but anyone can experience them. So your uterus definitely wants to cramp down at the end. That's how we try to prevent heavy bleeding. And so it's a normal response. It's what we want our body to do. Sometimes it's not the most comfortable thing in the world. And it seems to be the more babies you have, the more common and more prominent, maybe a little more painful that is. The one that I was surprised about was night sweats. And I don't know, even going through training, I did not realize night sweats were a thing. But when I had my first child, I remember the first 6 weeks, I was waking up in the middle of the night in pools of sweat. And I was like, what is going on? But it's normal. It's a hormonal change, maybe a little more common in your breastfeeding moms, but definitely normal. And it does resolve, does not last the whole year after delivery. And then the other one I was pretty surprised about was hair loss. All that wonderful hair you grew in pregnancy, you looked so good with your bouncy hair, it does kind of start coming out. And it stops, I promise, you don't go bald or anything, but just recognize that some of it's gonna come out a little bit. And then last one, I think people are sometimes a little surprised when they get a little bit of anxiety or depression postpartum, especially if you're not someone that's experienced that pre-baby. And so we want to make sure that if you are experiencing those things, you make sure you're talking to your provider and using your support system so we recognize it early and we can help treat and help you out a little earlier.
All right. So in addition to being a healthcare professional, you're also an experienced mom. I saw your baby earlier, and parent. What were some of the initial challenges that you faced as a new parent, and how did you get through them?
Well, so I have three. My youngest daughter is here. She's 9 months old, kind of walking around with Dr. White, which is one of our partners. But the struggles, I think, for me in the beginning, I was up in New York. I didn't have a big support system and family system, and I was in training at the time, so I had to go back to work pretty early, around 3 to 4 weeks postpartum. And so I think a big part of what I struggled with was being a little worried about continuing my bonding with my children after I went back to work. I didn't really have that long period of time to see my baby every day, and I would go for 24-hour shifts. And I think a lot of moms experience that, having to go back to work and that fear of going back to work and leaving your baby at home or going to daycare and so on and so forth. And so I think that my husband and I kind of sat down and we tried to figure out what were we going to do to kind of keep that connection, even though I had to go every day. And we utilize things like, our babies respond to our voices and our faces and those kinds of things. So we did a lot of, talking on the phone over speakerphone so my baby could hear my voice and I could hear my baby. And then we did a lot of FaceTiming, which the American Academy of Pediatrics approves FaceTiming as a screen time for babies. So we did look that up beforehand, but making sure my babies were seeing my face even though I wasn't there. And that was kind of a way that we could hold our connection even though I wasn't there. And then other things that I struggled with, I like to do things on my own sometimes, and asking for help is a little difficult for me, or certainly was with my first baby. So I think that, and you're quite overwhelmed like you haven't been before in that first period of time after you have a baby. So really vocalizing when you need something and what you need, because I think that the majority of people that do want to help, but they might not know how, and they don't know that they don't want to step on your toes or maybe do something in a way that you don't want them to do. And so I think really verbalizing, hey, I need a shower. Can you come and watch my baby for a little bit? Or can you feed my baby a little bit? Or can you just take him or her for a little bit so I can do something that maybe benefits me a little bit? Because you have to take care of yourself as well, is really important. And the vast majority of people I know responded very well to it. They want to help, they just don't know how. And so kind of making that known to them is really important.
Thank you. Lots of great information. All right, so we'll go on to Miriam, our nurse midwife. Many moms have a plan and vision of what their childbirth experience will be like, but things don't always go as planned. So what's the best way for moms to plan for any outcome?
I think flexibility is the key, and I will tell you that my moms who practiced 7 months of he-he-hoo perfect Lamaze breathing and then found that at a certain point they needed to go to hoo-hoo-he, that was a real challenge for them. Just like I've had moms who've come in about ready to push a baby out and held the kid in until they got an epidural, which takes a while, and they could have had the baby. I think in both extremes, it's about control and flexibility. And, I do encourage people to do birth plans. 95% of what people put on their birth plans are things we do anyway, and I think that's important for people to know. This is a parenting issue. Having a baby is a physiologic process. And yeah, sure, there can be issues, and fortunately we're all here and experienced and have different expertises to know how to address that stuff, and we all work really well together as a team. But having a baby and a baby growing up, being a parent, are not illnesses. And so, your OB provider, your pediatrician, it's a lot of education and teaching and what we call expectant management, and flexibility. And so I think being open to outcome. One of the best situations that I have experienced with someone who ended up needing a C-section unexpectedly was her doula saying to her, okay, so here's your birth plan, but but the other part of your birth plan is your what-if plan. So let's look at your what-if plan. And it was fabulous. It was absolutely fabulous for this couple and their doula to not only have said, ideally, we want to labor in the tub, we want intermittent monitoring, we want the baby to go right on my breast, we want, we're hoping for all this stuff. But when things didn't go that way, they also had a chance to talk through and say, what are the pieces that we can still do? What are the alternatives? Because there is a point at which all of us, but there is a point at which you have to give up control. And you have to give up control as a parent too. I mean, let's face it, your kid is gonna roll off the bed sometime, right? You cannot protect your kid for its entire life. I could tell you any number of things that my boys have done, right? I mean, this stuff happens. Boys. Yeah, Scale has them too. I can tell you any number of things that my kids have done, and I think being able to let go of the assumption that we have complete control and are going to do it perfectly is probably the most useful thing in the world. Oops, I messed up. Oops, that didn't go the way I was expecting. Oh, I thought the issue was going to be back pain, but instead it's groin pain. I don't know, whichever, I think control is a understandable, normal reaction to the fear of pregnancy and parenting and the absolutely bananas, scary culture that we live in. And we need to name that. We need to name the fact that our culture can be very toxic around this. But we also, in the same way, I think we need to find ways to support people. For pregnant women, I think we have to find ways to pamper and support and protect pregnant women and kids without infantilizing them or making them feel like they can't, ever wear a 2-inch heel or whatever the flip to the assumption of scary disaster is. We gotta find the balance, and that's in your birth plan, that's in how we as a team, Dr. Doback and I had a fun little text thread a couple of days ago because, we need each other. And you guys need each other in your parenting and in your pregnancy care.
Yeah. So should moms be creating a birth plan?
Absolutely. But if you don't, that's okay too. Again, most of what people put on birth plans are things we do anyway. And there are gazillions of them out there. There's a TMH one. We encourage you to think about that stuff. We encourage you to also do the what ifs. And not because you need to over worry about every whatever. I will tell you that when I was pregnant with my first one, I had this ridiculous thought in my head of what was going to happen in a certain situation where there was going to be a disaster and I was going to be home alone and the door was going to be locked and how was I going to let the EMTs in? And, you know, it spins in your brain, and that's normal. And then what I ended up as a challenge was not something I had ever anticipated, and that's normal too. So I think plan with a lowercase p, not a capital P, capital L, capital A, capital N, you know, go for it. Talk it over with your provider, but include your open to outcome stuff too.
So Miriam, when a mom doesn't plan to have a cesarean, which I don't think most of them do, but ends up needing one, it can be scary and emotional. Some moms may even feel a sense of loss for that birth experience, for sure, that they wanted. So what's your advice to them? You probably answered it.
I partly think I answered it because I love the idea of, you know, sort of plan A and then plan A minus, not to make it a, you know, it's not a failure, it's not plan F. But I think talking about, I often say to people, tell me your story. Tell me about so-and-so. Tell me, and you know, the name of your child. Tell me whatever. It's hard, though, for all of us in our busy, crazy, overscheduled office lives to be able to do that. So, you know, hopefully you have lots of other people who you can share your story with. And know that there are lots of fabulous resources for processing when things don't go the way you expect them to. That's going to happen in parenting too. Things are not going to go the way you expect them to. I have a kid who, you know, had a fabulous trajectory with a big dip because that stuff happens. We had a family situation that, you know, these things are going to happen. I have a kid who's doing brilliantly, but boy, did it take him a whole lot of wild and crazy diversions to get there. What I expected, who they are as kids, they're very different. And it's the same thing, I think, with pregnancy and childbirth. We assume that everybody is a 36C. Hello, we're not all 36Cs, right? When I teach puberty, I deliberately say to people, you know, the range of normal in our bodies is like the range of normal of women's breast sizes. You got the ping pong balls, you got the bowling balls, you got everything else in between, and our culture wants us all to be 36Cs. Our culture wants us all to be in control and only doing it one way. This is ridiculous. So we have to call it out, and we have to talk about it. And we have to take advantage of the many resources that we have with all of those pieces.
All right, thank you, Miriam. So back to Dr. Verstoffel, just briefly, how can mothers, whether they deliver by cesarean or vaginally, best bond with their babies right after they're born? And what about after they go home?
So we purposefully do something called the golden hour, which is the first 60 minutes after your baby is born. We would ideally like baby to be with you. And we don't do things like weigh the baby or measure the baby, give injections, do blood draws, clean the baby, nothing like that. It really is a time for you to be with your baby so you form this nice bond. And so, especially with vaginal deliveries, if you deliver vaginally and baby comes out crying and looks wonderful, baby goes immediately to you. And your nurse will help kind of lower your gown and maybe do skin to skin, because that's a great way to bond with your baby. And that baby will stay there for the first hour as long as baby's doing well. And it's a great moment to really build that bond. Not all deliveries, like we've just talked about, end up with this vaginal delivery like this. So there are times where maybe baby isn't doing as well and baby doesn't immediately go to you. Or if we do C-section and the pediatrician in the room takes the baby and monitors the baby for a little bit, usually in those situations it's for a few minutes, and as soon as baby is able to, baby goes to your chest. Even in the operating room, baby goes to you. You can see your baby, hug your baby, and have that moment. Sometimes we have babies that need to go to the neonatal ICU. And the NICU nurses and the neonatologists, they're wonderful. They try to give you as much opportunity to bond with your baby, hold your baby within reason, and when it's safe for your baby. So they do really want those opportunities for you to be with your baby. That's the biggest way of bonding in the hospital. Outside the hospital, you might be surprised because it's usually pretty natural. I mean, not everyone, but most of the time, things that you're doing that are normal equate to bonding with your baby. Things like holding your baby and cuddling with your baby, kissing your baby, singing, eye contact with your baby. These are all things that are forming a bond that are very natural that you do anyway. Certainly breastfeeding is helpful in that situation because you do a lot of skin to skin, but even doing skin to skin at home when you're bottle feeding can be helpful to continue building that bond with your baby. Talking to your baby is extreme. That's why I was trying to do the FaceTime and over the phone talking with my children, because them hearing your voice and you hearing them and seeing them is also just part of this bonding moment. Not everyone has this big bond with their baby at first, and that's totally normal. And so we can't expect that 100% everyone's gonna feel this amazing bond with their baby. But I will say that over time, a lot of people do get to that, and that with these small things that you do, you grow that bond every day. So it's very important to try to kind of get to that point where this process is very natural, and over several weeks, you might get closer and closer to your baby. And if not, definitely talking to your providers and using resources out there to help you is going to be important.
Can we also talk about skin to skin for dads?
Mm-hmm. Yes, skin to skin for dads is great. Just take off your shirt, middle of the labor.
So Dr. Doback, something that catches some mothers off guard is having a pregnancy that is deemed high risk. I had a high risk because I was over 35 with both of mine. Can you talk about what that means and what does it mean for a pregnancy to be high risk and what causes it?
Great questions, and I think a lot of us feel a sense of guilt if you get deemed high risk, but it's more a teamwork approach is what we're at least trying at TMH. Is we know per the CDC and the World Health Organization that we have seen a significant increase in pregnancy complications. So we're trying to see what we can do to help get better outcomes and bring those complication rates down. And so there are a number of different reasons you could end up seeing a high-risk specialist. One of the more common ones is just preterm labor, just going into labor early or starting to contract early. Not an unusual thing to happen where you might spend a night or two in the hospital while we try to get the contractions to slow and maybe get some steroids on board. Many of us might have some underlying medical conditions that can sometimes add risk to the pregnancy. Hypertension is probably one of the ones we're seeing more of, but diabetes as well, lupus, thyroid conditions, all those underlying medical problems can add some risk. In another area, sometimes we'll notice things with the baby. Sometimes the babies aren't growing as well as we'd like. Sometimes we'll find some abnormalities that may just be minor, that just need some follow-up after babies are born, which wouldn't change where you deliver or how you deliver or when you deliver, but just things we want the pediatrician to keep an eye on. And of course, then there are those conditions where sometimes we'll need to send patients either to Wolfson's or Shands just to have some other specialists see them because they might need some things done immediately after delivery. And so a lot of it is we're just trying to be more of a team, especially here at TMH, and we have amazing midwives and OBs here in town, and so we just try to help them and answer questions and sometimes follow your baby a little bit closer if there's anything we're seeing where we're not on a standard growth curve.
Okay. So you may have kind of answered this already, but once a woman knows her pregnancy is high risk, where does she go from there?
Sometimes it's not known until you're in labor and delivery with the contractions or if there are any issues with, the bag of water breaking early. So if you're in the hospital, of course, then we'll oftentimes be involved and either help take care of you while you're in there or set up outpatient visits with your midwives or OBs in our office. Sometimes we'll know before the pregnancy. We do a fair number of preconception consultations so we can have conversations with moms and or couples to kind of talk about what to expect and what sorts of risk might be involved with their pregnancy, what that might mean to any future children and to their future health. And sometimes it'll be something seen early on in the pregnancy where the midwife or the OBGYN will either find something on blood work or something on ultrasound, and then they'll refer to us.
Okay. Does having a high-risk pregnancy automatically mean that your child will have high-risk conditions? Does the risk end when the baby's born?
The good news is many times the baby will be fine. Our goal is still a full-term healthy vaginal delivery in most cases. That's still our goal, and all the providers in town I know strive to get that. High-risk conditions sometimes might mean we deliver a little bit earlier, sometimes 2 weeks, sometimes a little bit earlier than that. And of course, there are some conditions where we have to deliver much earlier, and prematurity might have some effects on the baby, so there is an overlap there. And then there are those situations where the pregnancy is deemed high risk only because of things we find on ultrasound, and then of course that has a much bigger effect on baby than any maternal condition might.
All right, with all these things that we can't control, there are also some we can. So how can moms set themselves up for the healthiest pregnancies and childbirths possible?
We encourage everyone to be as healthy as you can prior to conception. Certainly, we want everyone taking a prenatal vitamin prior to conception. We think there's definitely been shown value for the baby with the extra folic acid and the additional vitamins. And myself included, are guilty of maybe not being physically active enough, and so we also encourage physical activity. I think exercise in pregnancy has definitely been shown to be safe. American College of OB/GYN strongly encourages that as well.
All right, well, from the perspective of the dads, we talk a lot about the moms and the babies, but the dads, how can a mother's partner best provide support before, during, and after the baby's born?
I think just realizing the significant physiologic changes that occur, it is a lot of work on mom, even just the changes in the heart, how much more the heart has to work. So being supportive, trying to help where you can. There, as Dr. Forsthofer mentioned, there's a lot of fatigue, and that's normal and expected. And so allowing them that time to sleep and nap, because I mean, they certainly don't want to, but I mean, it is exhausting. Give them that opportunity. Go to as many prenatal appointments as possible, just to be supportive and hear what the providers are saying to them, and so you can understand what the recommendations are, what concerns they may have addressed. And do as much as you can to support them during the labor process, postpartum, and especially when the baby first comes home. There are a lot of physiologic changes that occur even after you deliver, and that physically can take a toll. Postpartum blues is real, it happens, so always be attentive to any concerns they might have, any help that you can offer them, because it is a lot of work physiologically, exhausting, and there are so many changes that occur that it's important to always do what you can to support, help, and then get help if you're having trouble providing the help.
Yep. So welcoming your first, second, or even fifth child can be intimidating. So what resources are available for parents as they're preparing to have a child?
TMH does a great job providing resources on parenting, on infant CPR, changing diapers, and I think that's a great place to start. The hospital wants to do everything we can to help make it a successful experience for you, help get the healthiest moms and babies possible. So don't hesitate to reach out to your providers, your midwives, your OB/GYNs if you have any concerns. Reach out to the family care unit after you deliver, ask them what resource they have, because the hospital has really gone to great extremes to try to make sure they provide you with every opportunity to get the information you need and get the help that's available.
All right, thank you, Dr. Doback. So we're gonna go on to Becky, our NICU nurse. One fear that often comes with pregnancy, especially high-risk pregnancies, is that the baby will arrive too early. So how early is too early, and is that something families can prepare for, and how?
It's a great question. First, I want to start off by clearing up some misconceptions and maybe some misunderstandings about NICU and prematurity. So babies of any gestational age could be admitted to the NICU for a variety of reasons. A lot of people think that the NICU is only for premature babies, but we actually do take care of full-term babies who have complications of a variety of things. So the other thing is prematurity is, lots of people think of prematurity as the very tiniest, the most premature babies, but Prematurity is any baby that's born before being full term. Those babies potentially, even if they're born at 35 weeks, which is really close to being term, could need NICU care. So I just wanted to clear that up. But to go into, in regards to what is too early, obviously, and Dr. Dobak said this earlier, obviously the goal of all pregnancies is to get as close to full term as possible before delivery. We know that there are situations where that becomes unavoidable or unsafe for the mom or the baby, and the baby comes early. In terms of the threshold of viability, which is when is it too early for medical care, it's changed throughout the decades. I've been doing this 20 years, and it's changed even in the 20 years of my practice, and technology has advanced. But currently, according to current research, the age of viability is around 23 weeks. And then I think the second question was, how can families prepare for this? Having a preterm baby, especially extremely preterm babies, is difficult for everyone. I can speak from personal experience. At my third pregnancy was high risk. I started having preterm labor at 26, 27 weeks and started bleeding at work at 28 weeks. And led to being on bed rest and all that. So here I am, a NICU nurse with the fear of delivering a preterm baby. So as you can imagine, the anxiety was probably triple what everybody else would experience, because I know a lot, I've experienced a lot. So it is difficult, and there's a lot of anxiety that comes from that. So there's not like a exact way to prepare for that. So I kind of just made like a little list. Take care of yourself and follow your doctor's advice. Continue to speak to doctors like Dr. Forstoffel, whoever your OB is, Dr. Dobak. These professionals have experience with moms in high-risk pregnancies. They've seen moms deliver very prematurely, and they can give a lot of advice and kind of help guide you along the way prior to that happening. Surround yourself with a support group. Whoever your support network is, family, friends, lean on them, talk to them. They're going to be your biggest support prior to delivery and then also after. I would also advise to use caution when reading things online. There's a lot of really scary stuff out there that isn't necessarily going to be the same situation as you. If I were to have looked up at 28 weeks what was going on with me, I would have read things that didn't actually line up with what was going on with me, but it could have made me terrified. So there are things that are not necessarily the same, but also there's a lot of incorrect information out there. So that's where your resources come in. And then if you're in the hospital and it looks like preterm delivery is imminent and that's going to happen, we can do a neo consult where your OB can contact our neonatologist, and our neonatologist can come to your room and discuss with you in more detail what to expect and answer any questions in that moment.
Okay, Becky, let's talk a little bit more about the NICU. It's something parents should consider when choosing a hospital for their delivery also. So what are the different levels of NICUs and why does it matter?
Well, this is a great question. It is absolutely something that all parents should consider when choosing what hospital to deliver at. No one wants or expects, like you said, it's not on anybody's birth plan for their baby to go to the NICU. So most of our admissions are unexpected or they're emergencies. So delivering at a hospital with a NICU is going to give you the peace of mind that there are people ready for the what ifs. Our neonatal team and our staff is always on the ready. So how our unit works is we're taking care of the babies, but if a code button goes off, which is there's something going on at a delivery, or they push that I need a NICU team button, it's like a big pause button is pressed at our unit. Everybody stops, a team runs off to go prioritize that delivery while the rest of the staff takes care of the babies in the NICU. So we're able to respond within seconds, minutes, whether it's a vaginal delivery or a C-section. So knowing that there's a team readily available to handle any situation that may happen, whether it's a preterm delivery or something that happens at your term delivery, the shoulder gets stuck or something's going on, we are there within seconds. That gives a lot of peace of mind. And in emergency situations, seconds do matter. And in terms of the levels, I'm glad you asked that question. A lot of people don't realize that there are different levels of NICU. And most of the time you'll hear about level 2 and level 3 NICUs. So then I get the question of, well, what is a level 1 NICU? We don't really have a level 1. That's basically your term nursery, your normal newborn care. At TMH, 20-something years ago, we had you know, the term nursery where you would see in movies with the glass and all the babies lined up. We do family-centered care at TMH, and so it's mother-baby couplet care. So the babies are with the parents. But we do have an area that if a baby needed to get labs drawn or have a circumcision or a car seat test, I'm missing some things, get short-term monitoring, that we do have that ability in our term nursery area. So a level 2 nursery is considered an intermediate care nursery. At TMH, we have a level 2 and a level 3. So it's an intermediate care nursery, and there are limitations as to legally what kinds of babies a level 2 nursery can take care of. In the state of Florida, currently, I looked it up to make sure I was right on with what was going on currently, a level 2 nursery can take care of babies that are delivered at 30 weeks of gestation or greater, and or have reached a weight of greater than or equal to 1,250 grams. So there is a limitation. So if a baby was delivered at a hospital that only had a level 2 NICU and they were outside of these parameters, legally they would be required to transfer the baby to a level 3 NICU at another hospital. In addition to any other baby that needs intensive care. So you could have a full-term baby that actually needs intensive care nursing, and if that baby is born at a hospital without a level 3 nursery, they would be transported to a level 3. So a level 3 NICU, which we also have at TMH, which is the unit that I work in, it can provide all medical treatments to any baby needing NICU care. It's highly specialized. We are required to have a transport team, which we do have, and we do use our transport team to pick up babies at other facilities that either don't have a NICU at all or only have a level 2. There are other situations that we'll pick up babies that need level 3 care. We also have an outpatient follow-up clinic for high-risk babies for after discharge. They come see us and we kind of follow up on their care. So I'm not sure if you guys are aware, TMH has the only level 3 NICU in the region. We have decades of experience in our unit as a whole, but also our staff. Many of our nurses have been here 15, 20. We have one that's been there 33 years. A lot of our staff, when they come, they stay. They love what they do. And so this wealth of experience really is amazing. It leads us to be able to be available for any emergency, any situation that arises. And if the benefit too of if you deliver at TMH and your baby happens to need level 3 care, mom and baby will get to stay at the same hospital, and they wouldn't have to be transported anywhere else.
You also have fabulous lactation services.
Yes, that's on my list for later. Yes,
for preemies.
Yes,
fabulous.
we have lots of things like that. Yes.
Yeah.
Okay, how else might your baby going to the NICU change the postpartum experience? For instance, mom might have planned to be exclusively breastfeeding, but having baby in the NICU changes that plan. Same goes for skin to skin. Will mom still have those opportunities with the baby in the NICU?
Yes. Breastfeeding and skin to skin is absolutely something we prioritize in the NICU. You don't get to miss out. You don't have to miss out on those experiences, but they will look different. Kind of like what Miriam was saying is, it may not be exactly as you had planned, but we do have that happen. So in the NICU, we do have a dedicated lactation consultant. Her name is Brenda, and she is fabulous. All of our NICU nurses are trained in lactation, so everybody is able to help you 24 hours a day. So premature babies and very sick babies are not going to be able to breastfeed or take anything by mouth for a little bit of time. And so that's where it's going to look different in terms of breastfeeding. You may not be able to breastfeed your baby right away. However, you can provide your breast milk. And so we have hospital grade pumps that are at every bedside for moms to use while you're visiting. And if your baby is eating, we can provide your breast milk straight through. Usually it's a feeding tube to be able to give your breast milk still to your baby. So that's still really important. And when your baby is old enough or stable enough to be put to the breast, that is our priority. We have a procedure in which that happens. With our premature babies, they aren't able to suck, swallow, and breathe until they reach a certain gestational age. And usually that's around 34 weeks. Some babies it's a tiny bit before, some babies it's a little bit after. And so we need them to be able to suck, swallow, and breathe without choking before we can put them to breast and be able to breastfeed. So we actually have a process that we do to prepare the babies for this. Is we start with nuzzling at an empty breast. So when babies aren't quite ready to suck, swallow, and breathe and take that fluid in, we can let them start nuzzling at the breast, where they can smell mom, they can maybe even lick, they can taste mom, get used to the position, that kind of thing. And that's really great for mom's breast milk as well, and bonding. So we do that when they're too early to breastfeed, but we want to start introducing them to this whole process. Then we move to something called non-nutritive breastfeeding, which is where they're not actually taking in any milk, so that we're letting them latch onto an empty breast. So they can practice the sucking and breathing part without having to swallow anything, so that it decreases their risk of choking. And then when they progress to where we can see that they can suck, swallow, and breathe all at the same time, then we can work on latching and breastfeeding with milk in the breast. So it does look differently, but yes, breastfeeding is still something that you can do in the NICU. Same with skin to skin. We are big into skin to skin. Our goal is that every baby gets to be put up on the chest of mom or dad as soon as they are medically stable. So it does happen, and it's different for every baby. So some babies, it may not be right after delivery, and in our extreme cases, it may be a week before you can do that. But we do, as soon as the baby is stable enough, we do kangaroo care right there in the NICU. Even babies on a ventilator, if they are stable enough with all the other things, we can get a team in there to help get the baby on mom.
So having a baby in the NICU can be a very emotional experience for families, being separated from their baby immediately after birth and sometimes even returning home without them. So what's your advice for those families?
Yeah, it's really hard when things don't go as you have planned or had hoped or expected. So some advice I have, first and foremost, I would say is just take a deep breath and look at your baby. A lot of times when babies are admitted to the NICU, it's really scary, and all we see are the wires and the tubes and everything that shouldn't be on our baby. So my advice is to try and look beyond that and look at your baby. Look at their tiny fingers, their tiny toes, look at their hair, look at all the things, and just really take that in and take that moment. That helps with bonding. We will teach you how you can touch your baby. It does look different depending on if your baby's premature or your baby's very sick. There are different ways that you can touch them, and the nurses will teach you how you can still touch your baby. Talking to your baby, singing to your baby, reading stories to your baby. Those are all really important parts of bonding. So that's my first piece of advice, is don't forget that your baby is your baby. And yes, there's medical equipment, but try and look beyond that and look at your baby. The second thing is let yourself feel whatever emotions you're feeling. You're gonna feel so many different emotions, whether your baby's in the NICU or not. You get this crazy surge of all these emotions. But as a NICU parent, you're gonna feel scared. You might feel angry. You might feel sad. You might be really excited because you just had this baby. And so let yourself feel the emotions that you're feeling and not bottle them up. Talk to someone, your partner, your family, your doctors, your NICU nurses. We become family in the NICU. We see ourselves very much as a family. We really bond with the families that have babies in the NICU. So talk to us if you need someone to talk to your doctor, but let yourself feel the emotions. Take care of yourself. Dr. Dovak mentioned this. Take care of yourself. It's really important, especially when you have a baby in the NICU, that you have to leave when you get discharged before them and they're still in the NICU. Make sure you're eating, drinking water, getting sleep. Those sound very basic, but those are the things that we tend to give up when we're focused on our child. If you overdo it, what we've found is if moms and dads are kind of burning the candle at both ends and they're completely exhausted, they're not able to focus on our collaboration of care when we're talking to parents about what's going on with the baby. They're in this brain fog because they're so exhausted and they haven't eaten anything. Or it's time to do kangaroo care, but they're so exhausted that they can't enjoy the moment. So go home and sleep in your own bed. You can call us anytime you want, but take care of yourself. It's really important. Write down questions and don't be afraid to ask the questions. It doesn't matter if you've asked us the questions 25 times. We know your baby in the NICU is new and is scary and it's unfamiliar. So don't be afraid to ask questions. Take pictures take pictures. Even with the wires and the tubes, you will regret not having pictures of your baby when your baby was that little or that sick. It is part of their story, it's part of their journey, and you will eventually be able to reflect back on that and want those pictures. But it also is good to take pictures and videos when you're at home and you're pumping. You can look at your baby and you can look at the video, and it'll help with your milk supply and all that. I would also say not to compare your journey with anyone else's, whether it's in person or online. Yes, connecting with other people who have a shared experience, there is value in that. There's encouragement knowing you're not alone. But I will say everybody's journey in the NICU is different. Delivering at 28 weeks for me is going to be different than Miriam delivering at 28 weeks. Our babies are different. And so it can cause unneeded anxiety if you're comparing each other's journeys. So I would just say just take caution with comparing. And then Dr. Forstoffel mentioned this, accept help. Your friends and family are going to want to do something and they won't know what to do. So if they offer to make you dinner, bring you lunch up at the hospital, do your laundry, do your grocery shopping,
Clean your
accept it.
bathroom.
All the things,
People won't let anybody clean their bathroom.
Yes, accept the help, and that's even if you don't have a full-term baby, accepting that help, speaking up for yourself of what you do need. If you can think of something that you do need, speak up. People around you, especially if you have a baby in the NICU, people want to help, and they don't know what you need. So if you know of something you need, speak up, and if people offer, go ahead and let them do those things so that you can focus on yourself and the baby. Yeah.
Okay, great. That's great info. Whether a baby needs to stay in the NICU or not, all families should ensure the safest possible sleep setup for their little ones once they get home. Can you talk about the ABCs of safe sleep a little bit?
Sure, and I'm sure some of you have already heard about the ABCs of safe sleep, but I'll do a recap for those of you who don't. So A stands for alone. So your babies need to be by themselves when they're sleeping in their crib or their bassinet, their pack and play. So this is not co-bedding. It is not safe for your baby to be in bed with any person, or that is an adult or a sibling. The risk of that person rolling over on your baby is very high, and also your baby moving over and rolling into the sleeping adult or sleeping child is very high. So you do not want your baby to be sleeping with anybody else. They need to be by themselves in a crib. And this is also not to put your baby to sleep on a couch, on a boppy pillow. They need to be in a secure environment. That's a crib, bassinet, pack and play, and by themselves. So that's A is alone. B is for back. So when you're putting your baby to sleep, they need to be on their back. Until they're old enough to roll over on their own, all babies should be put to sleep on their back. And this means flat, not propped up on pillows or positioners. There are a lot of products out there that claim that they are to help prevent SIDS. If they are not putting your baby flat, they are not protecting your baby from SIDS. So the AAP guidelines and all of that say flat on their back. Side and stomach sleeping are high risk for SIDS. A lot of people think that if their baby spits up, they're safer on their bellies. That's actually incorrect anatomically. If you think of, you've got your trachea and then behind it you have your esophagus. If your baby is laying on their stomach and they spit up, by gravity, it's going to pool in the trachea. And so when the baby tries to take a breath, they will breathe in that milk and it will cause aspiration and choking. If your baby is on their back and they spit up, by gravity, it'll go back down into that esophagus and not be in that airway. So on their back to sleep. And then C is clear, so keeping the crib completely clear. I know there's lots of things that are super cute, bumper pads and stuffed animals and cute blankets, but actually those are really unsafe for babies. So boring is best, and that's what we teach in the NICU is a boring bed is the safest bed. So you want a tight-fitting crib sheet around that crib mattress. You don't want to have extra blankets, pillows, anything extra in the bed with the baby. We do in the NICU use sleep sacks, so those are wearable swaddle blankets. They Velcro, but they're wearable, so there's no risk of them going above the baby's face where they can't pull it down. So recap, ABCs is alone, on their back, and with a crib clear.
Thank you. So we're gonna finally get to Becky. Deborah. Whether they get to take their baby home right away or not, another thing that can catch moms off guard is postpartum depression. So can you talk about why new moms go through this and how common it is?
Yeah, sure. So about 10 to 15% of new moms are going to experience postpartum depression. And this is due to hormonal changes, this is due to new stressors, and I'll talk more about that too in the other questions, but anything significantly changing your body or, different experiences could trigger those those mood responses to having a baby. So again, this is a major life change, and so if you're already
Speak up a little bit louder.
If you're already prone to mood disorders and things like that, having a baby, bringing it home, and all the changes that come with the baby is going to make you more at risk for having postpartum depression. And earlier I mentioned 10 to 15%, so.
Okay, so what's the difference between the baby blues, because we hear about that a lot, and postpartum depression, and when should moms seek professional help for that?
So baby blues generally occurs right after you give birth, and usually it's just due to the hormonal changes that were mentioned earlier. You might experience some tearfulness, feelings of sadness. These feelings should clear up within 3 to 5 days, shouldn't last more than 10 days, and they're pretty mild feelings of dysphoria, maybe some nervousness, but again, mild, not too concerning and not too impacting on the mom's functioning. And 85% of moms will experience baby blues. So if you do start feeling moments of sadness, don't panic. It's normal. Postpartum depression is less common, but definitely more serious. Symptoms usually are more intense, longer lasting, and most cases will occur within the first 3 months, but can occur up to a year later, just depending on the mom's circumstances. So postpartum can have pretty harmful consequences for the mom and the baby. Symptoms include just lack of motivation, loss of interest in things. You might not be bonding with the baby like you should be. You could be having some suicidal thinking. You might have some thoughts about harming the baby, although they're not as common. Loss of interest, like I mentioned, emotional outbursts, and generally this is something that's going to be happening for more than 2 weeks for you to start being concerned. Mom should seek professional help if, again, you're having these symptoms for more than 2 weeks. If you're at all experiencing thoughts of harming yourself or a baby, it doesn't matter how long, just any thoughts, please go talk to somebody. If you're just having a hard time functioning, if other people are concerned about you, it might be good to talk to somebody. And then if you have a history of mood disorders, you should probably be monitored throughout that pregnancy anyways. And so it's good to check in with a therapist, letting your doctor know what's going on. If you just have a history of being diagnosed with depression, anxiety, bipolar disorder, anything like that.
So what are some of the other postpartum mental health disorders that may impact women?
Sure. So there's postpartum psychosis, which is very rare, but it is really severe. It occurs in 0.1 to 0.2% of women, and postpartum psychosis is the presence of hallucinations, delusions. Generally, this is what's going on when you're hearing about moms harming their babies, although that is rare even with the postpartum psychosis present. Extreme agitation, inability just to eat or sleep, functioning, not able to hold on in conversation, so anything like that. Definitely seek professional help if any signs of postpartum psychosis are occurring. You're more at risk for postpartum psychosis if you've been previously diagnosed with bipolar disorder, which I know a lot of people are, but it's still rare. If you have had postpartum psychosis in previous pregnancies, if your family has a history of depression, and then if you've personally had a history of postpartum depression or just moments of psychosis, you're at risk for that too. But again, really rare, so.
But you can get help at labor and delivery triage. And I think, people think that once you've had the baby, we're not available to you anymore. I think it's important for people to know that the triage providers and the triage team will see you for a postpartum concern.
And then I also wanted to mention too, there's kind of an umbrella of mood disorders that might occur after having a baby that aren't necessarily specific, but instead of depression, you could have postpartum anxiety. And so it's just, again, kind of intrusive thoughts, worrying about the baby. It's normal to check on your baby and be concerned about it, but if it's impacting your functioning, also just something maybe go talk to a therapist or your provider about.
So how long can moms expect, I think you talked about this a little bit. How long can moms expect to wait until they might feel back to normal after giving birth?
Never, no.
It's a new normal.
It is a new normal.
It is a new normal. So I'm hesitant to even give a timeline on this. I will use my personal experience, but what happened was about every 3 months I started to feel a little more like I had it. And I actually probably did have postpartum anxiety, depression, and didn't do what I needed to do for myself, but I learned from that. So around the 6-month mark, physically I know you start to feel normal. Again, it's so dependent on the baby and your family and your support, but maybe you're starting to feel confident in your ability to keep your kid alive by the 6-month point. I mean, again, it's just so, yeah. So 6 months to a year is my hesitant answer for that one, but also know that if you don't feel normal, that's normal. So not feeling normal is very normal.
So what are some of the risk factors associated with perinatal depression and mood disorders? And is there any reason as to who is impacted?
Sure. So I just want to note that there's actually no difference in rates of postpartum depression around the world or different classes of people or anything like that. It occurs pretty evenly amongst countries. So with that being said, though, some of the risk factors, if you have a history of depression, it's a risk factor. If you're under the age of 25 and having your first child, risk factor. If you have a lack of support or perceived lack of support, also a risk factor. If there's a poor relationship with the baby's father, if you have a history of abuse, if you went through infertility treatments, that can be a risk factor. Sexual minority women, risk factor for postpartum depression. If you've completed a lower level of education, and if you're experiencing social stressors throughout the pregnancy or financial stressors, it's very challenging financially to have your first baby sometimes, and that can be a risk factor for postpartum depression. I think I mentioned most of the big ones. Also too, after giving birth, and again, learning to be flexible if that birth didn't go as planned, if it wasn't what you expected, if your baby's a difficult baby, if your baby has special needs, if you're just not getting the support, all things that can contribute to postpartum depression. So it's just really important to be aware and check in with yourself and, to see how you're doing, especially if you hit any of those risk factors.
All right, so bringing a baby home changes everything. It shifts the dynamics between mom and her partner. So what advice do you have for couples navigating this?
Don't threaten your husband to divorce him like I did in the first year. But seriously, understanding negative emotions are common and normal, and your hormones are going all over the place. And so understanding both of you are adjusting to bringing home this baby that has just changed up everything. Being flexible with each other, communicating with each other. Again, the support is probably one of the most important pieces of bringing home a baby. I had friends make me frozen dinners. I had a friend walk my dogs. My sister would come over so I could take a shower, like mentioned before. And honestly, it probably still wasn't enough support in my situation, but I still tried to let people help. And that's important too, letting people help, asking for help, having some sort of expectation when you get home, but also knowing your plans could go out the window just depending on the situation. Taking turns caring for the baby. Hopefully not one parent is primarily doing everything. Generally, there's one at home and one working during a certain amount of time, so I know it's important that the working parent gets that sleep, but also too, the mom needs the sleep too. So, you're healing. There's a lot going on, and just making sure that you guys are kind of agreed upon, okay, who's gonna do what and when is important. Trying to get that alone time with each other if you're able to, go out on dates, get out of the house, get away from the baby. We went and saw Black Panther, and I was so excited when my son was 6 months old, and I was like, oh my gosh, no baby. It was amazing. But it's good for you guys to just still spend time with each other, because that relationship, it's gonna be hard when you bring that baby home. And then if you need to seek a couples counselor, totally okay. It doesn't mean your relationship's over, just to kind of have a person there for extra support.
and know that your baby will be just fine.